They ask me, what can I do to help? What can I do to help? I said that you need to find what is the cause and manage the underlying cause. And for this patient, the cause of this is relapsing polychondritis. After they manage her polychondritis, and this all disappeared. Okay, what caused the reflux? When you manage a patient, the patient's voice is hoarse. Patient have thick endolaryngeal mucus. You do the scopes and you see a thick endolaryngeal mucus, edema, all are inflamed. When we treat the symptoms, we need to also know what caused this so that we can manage patient as a whole. What caused the upper esophageal sphincter to be relaxed and the acids goes up? Is it because of increased intra-abdominal pressure? What caused increased intra-abdominal pressure that caused the acid to be pushed up? Is it central obesity? Is it pregnancy? Is it any food that the patients easily triggered to? Any medications patients on? Any psychological influence? So all these factors, the gut-brain axis factor and sleep apnea, I will discuss it a bit after this. So when I give this, the treatment algorithm, it looks so straightforward, so simple, 3 months and see back. It is not as simple as this. So how we titrate up and how we titrate down managing laryngopharyngeal reflux? Other than PPI, we also managing reflux with Gaviscon, right? Gaviscon for mild laryngopharyngeal reflux, and we step up to PPI. In laryngopharyngeal reflux, usually we give BD dosing because the larynx is very sensitive to acid reflux. During the T half-life of the pharmacological effect of the PPIs goes down, we want it to be always high in concentration to suppress the acids. So we give BD. Patient still not satisfied, still symptomatic, then we can add on the prokinetics, domperidone and the etopride. So that is stepping up. Of course, before or with that pharmacological, you need to advise patient on behavior modification. For me per se, behavior modification, I think personally is the most important. If you see in the literature, you will find there is a lot of treatment algorithm. This is one of them. But the most important is you need to find why your patient is refluxing. You need to find why, and then treat the patient accordingly. The most important is you treat for the right diagnosis. When the patients come with symptoms, hoarseness, of coughing, of feeling of lump in the throat, LPR is not the only thing that need to have in mind. If the patient's inflamed in the larynx, is it because of the reflux or is it because of the postnasal drip? Is it because of environmental factors? Is it because of other cause of inflammations to the larynx? So diagnosis is most important. If you can see from this list, it's a long list that you need to consider. Sometimes what we do is, when the patient comes of symptoms of reflux, RSI is high, and then we do the symptoms, the reflux finding score, and then we just treat it patients empirically. But we always need to have in our mind what is the differential diagnosis if especially patient didn't respond. Okay. One of the differential diagnoses that I want to highlight in this lecture is about laryngeal neuropathy. Laryngeal neuropathy have been described as group of disorders that caused by laryngeal irritation. Let's see what are the symptoms. Sore throat, dysphonia, foreign body sensation, noisy breathing, chronic cough. Does this sound familiar? This is sound very laryngopharyngeal reflux, right? So in patients with laryngeal neuropathy, the pathophysiology of laryngeal neuropathy is much different from laryngopharyngeal reflux. In laryngeal neuropathy, it is because of sensitizations of the cough reflex and neuropathic response to receptor stimuli. So it have problem with both sensory and also the muscle. If you find in the literature, there are lots of names for laryngeal neuropathy. Why do you think there is no consensus? Banyak nama macam ni means that there is no consensus. Like laryngopharyngeal reflux, everything is this may be caused by this may be caused by this, means that there is no consensus. In laryngeal neuropathy, it sometimes be called as irritable laryngeal syndrome, laryngeal hypersensitivity, airway hypersensitivity, vagal neuropathy. So if you find this in your literature or patients you diagnosed with any of these, it means the same thing. Okay, let me bring you what is the similarities and the difference between these two. In voice changes, laryngeal neuropathy is caused by loss of control and weakness of the vocal cords, but in laryngopharyngeal reflux is because of irritation and inflammation. Throat discomfort in the LPR is because of the lump in the throat in LPR and throat tightness in the laryngeal neuropathy. Chronic cough in LPR caused by the throat irritation, but in laryngeal neuropathy is because of nerve hypersensitivity or infective cough, and they have overlapping. From these symptoms, you can see that in laryngeal neuropathy, there's not much talking about inflammation, edema, excessive mucus, right? So the larynx is quiet. The larynx is quiet, it's not inflamed, though the symptoms is about the same. So the treatment is gabapentin, amitriptyline. Okay, this is a new thing that is coming up now when we're managing laryngopharyngeal reflux. I mentioned to you just now the pharmacological treatment and also the behavior modification. So the gut renovation and laryngopharyngeal reflux falls under the behavior modification. What type of food? What type of probiotics? Do probiotics have microbiome have the effects for managing laryngopharyngeal reflux? This gut renovation, microbiome is lots of maybe. Now the research is ongoing, lots of research is ongoing on the gut renovations. They have lots of postulations. Sleep apnea and laryngopharyngeal reflux. I tell you just now, it's because of mechanism is one of it because of increase intra-abdominal pressure. The negative pressure in the throat. When do you think it is this negative pressure in the throat, especially during when? In sleep. In patient with sleep apnea. During the apneic episode. Why in the apneic episode there is increase in intra-abdominal pressure and negative pressure in the throat? Don't know. Because during apneic episodes, the patient will try to catch up breath. So the the diaphragm will be fixed. The intra-abdominal pressure will be high. So the pharynx will be relatively low in pressure. So the acids from the stomach is pushed up into the pharynx and larynx. Reclined sleep position. That's why in laryngopharyngeal reflux, one of the things that we can advise patients is to elevate the shoulder and the head. It's not only the head down, not like this. The shoulder and the head to help with the gravitational for the acid, prevent to reflux to the pharynx, larynx. Not only that, the impact of the NPR to the sleep quality, especially in the patients that wake up coughing at night. So here you need to take a very good history. Did the patient wake up at night because of cannot breathe? Or is it because of irritations by the refluxids? A good history taking. And because of the if it is because of the irritations of the refluxids, and patient have frequent arousals, so it affects the patient's sleep quality. And also the role of inflammation. Low sleep quality, bad sleep quality, inflammation is a vicious cycle. So how we advise our patients? Elevate the head, avoiding meals and snacks before bed. Why? Because we don't want during sleeping there are still acids is built up in the stomach, so it will reflux up. Mindful of few food choices to the patients. We need to ask patients, you need to be mindful what type of food that triggers you to have more acid production, that you have more symptoms. So you really need to take good history with the patients, and the patient, when the patients go back, they need to be mindful on what they eat prior to the increase of the symptoms. Establishing a relaxing bedtime routine. This is to reduce, it's a routine to reduce the cortisol in the patients, that signaling the body that it's time to round down, reduce the anxiety and stress. Anxiety and stress, we all know that can induce acid production, and maintaining good consistent sleep. Sleep schedule, creating comfortable sleep environment, and limiting the stimulants and alcohol. Sleep, stress, and reflux, they are a vicious cycle. Okay, so alginate and NPR. Alginate, the most common we use in Malaysia is the Gaviscon. So Gaviscon have two mechanism of action in managing laryngopharyngeal reflux. Number one, it forms a barrier. It forms a barrier. So that when the patients take, especially in alginate, we can give patients until 4 times a day. 3 times during wakefulness, and the 4th time just before the patient goes to sleep. If the patients have the most troublesome or have a troublesome symptoms of laryngopharyngeal reflux when he or she wake up from sleep, you advise patient, please take the Gaviscon before you go to sleep. So this will ease the patient's symptoms very much. Also, we give alginates in patient with mild reflux. So not all patient NPR, PPI, NPR, PPI. No, in a mild laryngopharyngeal reflux, ask the patient to try on alginate first, in a mild one. Okay, and it also have antacid properties. You know that alginate, they have Gaviscon regular, advanced, double action. So they have sodium bicarbonate and calcium carbonate, that properties that have antacid properties. But the main role of alginates is forming the barrier. Breathing exercise. This breathing exercise looks easy, can help for laryngopharyngeal reflux. There's lots and lots of study says that doing breathing exercise can reduce reflux. How? How did breathing exercise reduce reflux? Number one, it can regulate the intra-abdominal pressure, and also it can strengthen the muscles of the diaphragm, hence prevents the acid reflux to the pharynx and larynx. Activations of the vagus nerve. Vagus nerve is the nerve for rest and digest. By stimulating the vagus nerve, the body will be out from the stress and anxiety and come into the rest and digest. So these rest and digest states will move out patients from the body from secreting a lot of acids. And also, yes, breathing exercise to reduce stress. I mentioned to you just now, improve the lower esophageal sphincter function. Exercising, breathing exercise, strengthen the diaphragmatic muscle and can improve the function, hence it will enhance the closure of lower esophageal sphincter. You can send the patient for breathing exercise to our speech language therapist, and you can send the patients to our physiotherapist also. They offer this breathing exercise. The methods berbeza. If you would like to know, you send half of your patients to speech therapist, you send half your patients to physiotherapist, and the patient will tell you there's a lot of technique. There's a lot of technique. If the patients really do the breathing exercise on top of other things, it helps. The study shows it really helps. Okay, so what we as ENT usually do, especially when we want to reduce the waiting time in the clinic for 30 minutes, we give PPI. Hacham patient give a history of reflux, PPI. In my center, doctor, we give OD PPI. All patient we give OD PPI empirically. Very easy. Patient datang, orang lain pula tengok. Sambung PPI. Sambung PPI. Okay? It's not good. It is not good. PPI is only for acute troublesome symptoms. The patients need to know what aggravates the reflux. Patients need to be mindful of what they can do to their daily lifestyle so that they can live reflux free. It's not for forever and ever PPI, no. I saja letak satu slide panjang-panjang. I tak bagi-bagi. Do you know why? Too many side effects. I want to convince you all. Too many side effects. I once read lah dekat social media, why doctors give to us PPI for years and years and they know already they have lots of side effects. Because it's easy now. You just put in any chat box, ChatGPT, anything. These all things will come out. And the patient says why the doctors doesn't think about the complications. The PPI give to us and just prescribe mindlessly PPI to us. So titrate up, titrate down, take a good history, become a great doctor, take care of patients well. Yelah, in government setting, you say, alah nanti lagi patient tak ramai datang lagi bagus. Kalau dekat private tak apalah, kalau jadi, no. You want to become a great doctor. Kindly treat your patients well, take care of patients, good history, mindful of the other differential diagnosis, not just knee-jerk reflex. It is a laryngopharyngeal reflux, and you will treat your patients well. I think that's all for me. Thank you.
Ms. Nik Fariza for the succinct lecture. Our next lecture will be on office procedures in urolaryngology. Once again, I would like to invite Prof. Mawada to the stage.
Thanks for the